Good evening, everyone. I'm Dr. Ramakrishna from TCT India. I would like to welcome you all for the Arena 3 for third day of sessions. That is talent presentations. I would like to welcome chairpersons and panelists, Dr. Vijay Trehan, Dr. KK Sethi, Dr. VT Shaw, Dr. Karupaya, Dr. Ganeshan, Dr. Keshav Murthy, Dr. Shubhan, Dr. Sujata, Dr. Veeramani, Dr. Ravi Cherian, Dr. Sudhakar Rao. Over to you, VT Shah, sir.
Session now. That would be about all the interesting angios. Saying India has got talent. Watch and learn. Of course, we are here to watch, learn, interact, and educate, inform, everything. So let us go to the case 1, which is by Dr. Arun Kaushik from PSG Hospital, Coimbatore. Small diffuse vessel with bifurcation disease. Very interesting. Yes, and an interesting topic also, which we face day to day many times. So over to you, Dr. Arun.
Topic for the TCT conference is focused usage of imaging and physiology in a small diffuse and in a bifurcation situation. I myself, Dr. Arun Kaushik from Coimbatore, India. The patient is a 50 years old female, a non-diabetic, a short stature. She had come with wrist angina, diagnosed to be ACS, STEMI, and subsequently her COVID RT-PCR was negative, but with the CORAD score of 3, and echo showed a moderate LV dysfunction with regional wall motion abnormality, both in RCA and LAD. And she had a continuous wrist angina, which was refractory to maximal anti-anginals. And she also had both heart failure and COVID sequelae. So she had breathlessness because of both, and she was stabilized. This was her angiogram. You can see the lady was diffusely diseased vessel, and there is more than TIMI one flow, and you can always also see an RCA filling through heterocollaterals, and there's a codominant circ with a lesion in the major OM, which is a bifurcation lesion. So this is the lesion in the OM, and you can see the diffusely diseased LCX, and you will see the RCA, which is filling through heterocollaterals. And this is the codominant RCA, which we can see a critical lesion here with a reduced flow distally. So in this scenario, we have a typical multivessel PCA involving the LAD starting from the proximal until the distal with a very poor caliber vessel, small caliber. And we have a lesion in the LCX, which is across the bifurcation, and a codominant RCA and a critical lesion. So in this scenario, which we have a syntax score is also in the intermediate zone. So I had plans of both CABG and PCA, and I just had a plan of doing an discussing both what to do to send her with CABG, considering the long-term outcomes, but in a poor diffusely vessel, and in terms of COVID and wrist angina and the practicality involving the CABG, and the same ways, in case I plan for PCA, I thought I'll do an RCA as an ad hoc since it has a TIMI one flow. So followed by stage PCA to LCX and LAD. So I had options of DES with DCB for LAD and provisional PCA to OM. And the cost was a concern, and long-term outcomes were a concern, and COVID was a concern. So we did an ad hoc RPCA to RCA, and this is the final RCA shot, and she improved. Subsequently, she was discharged with her pulmo care, and subsequently her LV function also improved, and further plan discussed in regards to revascularization. So she was discharged on day 10. So when she came, and I had a plan of doing a multivessel PCA, and it was more in a live conference situation. And so I thought I'll start with OM1, do an RFR, then OCT guided PCA to OM1, and finishing the procedure, we'll do an RFR to the side branch because of the codominant LCX, then decide accordingly. Subsequently, LAD, do an RFR to localize the lesion, then pre-dilate, then do OCT, then decide about DES or drug-coated balloon. So she was in a better position compared earlier. So this is a first procedure. This is an RFR came to us 0.78, meaning significant lesion, and then PCI to LCX was done. So you can see there is a narrowing in the side branch. So this is the OCT, and this was a well optimized stent completely, and there is no mall opposition or under expansion, and the carina looked free. So, but I just want also to prove with physiology. So I did a RFR to the side branch. RFR to side bench was 0.98. So it was left alone as a provisional approach to main branch to distal proximal to main branch, requiring no extra stent in the side branch. So coming to PCA to LAD, so the flow decreased after RFR, where RFR was mainly done to localize the severity of the lesion to decide the landing zones, and pre-dilatation was done, and then did a OCT. So this is the pre-dilatation and the OCT run being done. We could see is the distal most caliber is diffusely fibrous disease, fibrolipidic plaque with the maximum diameter was around 2.3, and proximally they had a dissection here in the lesion site, and you can see the dissection involving more than a quadrant, and subsequently getting up to the adventia. And you can see the distal stent. I had a two-stent strategy. At this point, I had a discussion between DES and DCB, and in view of dissection, and more validated data in compared to the DCB, which is there is a discrepancy between the depth used in the trials and in reality. So I and after discussion with the panel voted in favor of DES, and this you can see the proximal stent deployment and subsequently post dilation being done in the overlapping areas and making sure there is no further distal dissection. So, and this is the final injection of both OM and here you can see the proximal LAD, and subsequently you can very well see the mid LAD where you have a dissection, and distal area and there is no distal dissection. This was the final OCT run, so which was very no, there is no dissection, edge dissection both proximal and distal, and it was there is no under expansion. So the learning points in this case is each multivessel PCA is unique, and COVID makes the situation more unique. RFR and OCT complement each other in demanding cases. DCB instead of DES in long diffuse disease needs more expertise and evidence. Decision making should always be open-minded in this sort of situations where real customization is required. Thank you very much.
Thank you, Dr. Kaushik.
Thank you, sir.
Yeah, for that interesting case of multivessel disease and making it simple by imaging and physiology both together. Now, just a couple of questions. First of all, the circumflex to OM. Was the RFR done after the kissing, before the kissing, or just crossover and then RFR?
So crossover, stenting is over, then RFR, sir, because of the added extra the stenosis by angiogram took more than the baseline. So we all decided whether it does require a conversion of crossover to two-stent strategy. And then I did a RFR, although anatomically it was worsening. RFR showed at 0.98 and it was very
Yeah.
convincing to.
So, but the RFR was done before the kissing balloon, after the pot or before the pot?
Sir, after the stenting, after part, sir, as the last step, sir, completion of PCA, sir.
Yeah, very good. So the reason why I'm asking is because
Yes, sir.
if you see the European club and even in their EBC main trial, FKB was almost like more than 90%, and that was an essential step they had said. Nevertheless, important is that decision was not based on imaging. Your decision was based on physiology, that you found that the RFR was normal and therefore you left it alone. Okay. The important thing is when you were doing OCT, why did you not check for the stent struts and links in front of the side branch? Because there are two issues with the side branch in provisional stenting. One is whether you have compromised the flow in ischemia, and the two is whether you have struts and links in front of the side branch. Of course, this second is not a proven hypothesis. Okay, so you may leave alone, but since you were doing OCT, possibly that could have been an added point. So that was one. The second was your LAD. So that was nicely demonstrated that the distal vessel was 2.5. Now the minimum stent which we have is 2 millimeter. So there was good enough size for stenting the vessel. But sometimes when you have dissection and a very long lesion, one can do a spot stenting also instead of two overlap. So how much was your dissection, whether you had some space to do a spot stenting or not, all those factors if you could have given us, and that would have been much more informative. I'm just telling you, I mean, some of the points. Of course, MLT max is standard.
Yes, sir.
Yeah, so that there is no issue about that or anything about that. So any of our other panelists who would like to ask question or comment or give more information?